Good morning to you. I'm Dimutu Muthukuda and my co-chair, Newmal De Silva. So we warmly welcome you to the second plenary of SLENDO 2025. And so we have Professor Mark Gurnell with us. Professor Mark Gurnell is not new to our audience. And if you were there yesterday for the inauguration, he was the guest of honor. And it's my privilege to introduce Professor Mark Gurnell. He's the section lead, Department of Medicine, Clinical SubDean, School of Clinical Medicine, University of Cambridge. And he is also the clinical lead, Endocrine Services, Cambridge University Hospitals, United Kingdom. And he'll be talking to us today on atypical thyroid function tests, avoiding the pitfalls. I think it's a privilege listening to you, Professor Gurnell, especially on a topic related to thyroid function tests. So I'd like to invite you to the podium to deliver his plenary.
Thank you very much for a very kind introduction. It really is fantastic to be here again, and I'm looking forward to the meeting. So we're going to kick off with a session on thyroid function tests, and this is born out of a practice in Cambridge, and actually Dimuthu had the opportunity to come and spend some time with us in Cambridge, where we have looked after patients with unusual thyroid function tests for many, many years. And what I hope I can show you in the next 20-25 minutes is my approach to trying to unravel these and trying to bring some order out of what sometimes appears to be a little bit chaotic. So I have no relevant disclosures for this talk. In many ways, this is going to be one of the two most important slides in the talk, because this is going to show you the broad headers and approaches to dealing with these unusual thyroid function tests. And I would strongly encourage you to break this down into three areas, because these are the areas from which the problems tend to arise. There are pre-laboratory issues, laboratory issues, and then what we do with the results when they come back to us. So step one, which I'm going to refer to, is how we recognize that we might be about to face a problem with thyroid function tests before it happens. So we can anticipate that we might see some results which are different to what we would normally expect to see. And I'll touch briefly on some of the physiological changes, but also bear in mind some of the confounding illnesses or medications that the patients may be on, which may produce some unusual test results. We then have to stop and think about what happens in the laboratory. So we send the sample to the laboratory, back come the results, and even with the best intention, when the laboratory is doing exactly what it should be doing, we may still end up with confusing results or results which are genuinely misleading. And then we must ourselves recognize that sometimes we might be dealing with a condition which is really quite rare, an unusual condition which could be acquired, genetic, that we have not so much familiarity with. And a crucial thing there is working out at what point we need to potentially seek expert input. So these are the three key steps that we need to go through if we're going to unravel these unusual thyroid function tests. So this is the first important slide. And this is the second important slide, which will be a familiar slide to many people, which essentially says at the end of the day, if you are stuck and you're not sure what's going on, if you go back to pattern recognition, most of the time you will be able to work these cases out. So these are the core patterns of standard thyroid function tests that you and I are used to seeing. Normality, overt thyrotoxicosis with appropriately suppressed TSH and raised free hormones, or overt hypothyroidism where the free hormones are low and the TSH is appropriately raised. But there are some other patterns that we need to acknowledge. So we may have apparently normal thyroid hormones, but with either low TSH, and you can see some of the potential causes in the top corner there, or potentially a high TSH with normal thyroid hormones. And again, some of the causes are just shown down there in that bottom corner. Equally, we may have free thyroid hormone levels which are low, but the TSH has not risen. And again, that is a pattern associated with some very distinct conditions. But today, as an illustration of how to take yourself through these unusual results, I will spend more of my time talking about that bottom corner just there, which are the patients who have thyroid hormones that are raised, but the TSH is not suppressed as you would expect it to be. And that's the set of TFTs, which I'm now going to use as an example of how to navigate steps 1, 2, and 3 to unraveling these. So, raised thyroid hormones, non-suppressed TSH. That means that TSH is either inappropriately within the reference range or may even be actually raised. Now, this is the most important thing that I teach all my trainees. Before you do anything else, please go back to the clinical context, because that will, as often is the case in medicine, give you the answer. Then think about laboratory assay interference, and that means you can now engage your laboratory with a proper conversation because you have already worked out where you think the problem might be. And the laboratory will thank you over and over again if you can give them a clue as to where you think the problem arises. And then you might need some specific conditions to be considered about which you might not know very much, but hopefully you'll be able to find reference points of people who can help. So let's go back to step one. So step one involves taking a careful history, thinking very much about the thyroid status. Now, this is a really crucial thing when you're having a discussion with the laboratory, because if you cannot work out which result is wrong, it's going to be a little more difficult for them if they have no guide. So if you see a patient who appears to be euthyroid, but actually the results are telling you that they're hypothyroid, then it's likely that they will be able to work out either the T4, T3, or maybe the TSH is wrong, depending on what the pattern is, and vice versa. So making an assessment, it doesn't have to be precise, but deciding generally whether the patient is thyrotoxic, euthyroid, or hypothyroid is something which should be recorded in your notes. Because by doing so, you've acknowledged that I actually have made a judgment about where this patient's clinical status is. Also, if they have any intercurrent other illnesses, non-thyroidal illness or acute psychiatric illness, then it's also important to document, because those can produce abnormalities of thyroid function which are normally transient and do not require intervention. So just knowing about the presence of those disorders can prevent you inadvertently going on and investigating the patient, and often confusing the picture further. And then medications. It's always amazing to me that everybody knows that amiodarone does something funny to thyroid function tests. A lot of people still don't recognize that the most commonly prescribed drug in hospital, heparin, is also very likely to produce abnormalities of thyroid function tests in specific settings. And in my hospital, it's impossible to get in the door without somebody injecting you with heparin. And that happens to me every morning on the way into work and every morning on the way out of work. But joking aside, heparin is commonly used and it can produce abnormalities of TFTs, but so can other drugs such as furosemide. And a resurgence recently, actually because of pediatric practice, actually still sometimes using chloral hydrate, of actually recognizing that that can produce a really unusual pattern of TFTs, which again is transient. So just to remind you, there are things which are genuine causes of alterations in thyroid function. Most laboratories, actually quite interestingly, present the same thyroid function test reference ranges across the whole of life. Now, if you're a pediatrician, you recognize immediately this cannot be right. There are various stages of the neonatal period through into adulthood where the reference ranges cannot be the same as those for the adult. But the same is true in adult practice as well. So if you actually take a group of healthy adults who do not have thyroid disease, they do not have the presence of antithyroid antibodies, they do not have any relevant family or personal history. Once you get to 70 years of age, you've got more than 5% of those. And once you get to 80 years of age, more than 10% of them with a TSH level, which is above 4.5. So this is normal. And actually, there's really good data that if you treat these people with thyroxine to try to get their TSH down, you shorten their life. So we need to think very, very carefully about where we're trying to change what potentially is normality. I won't spend very much time talking about the thyroid function test changes that occur in pregnancy, but everybody knows that as HCG goes up, TSH comes down, free thyroid hormone levels temporarily rise, and then of course importantly behind this, thyroxine binding globulin levels are progressively significantly elevated, and not surprisingly total thyroid hormone levels are elevated. So if you recognize all of that, then you won't get confused by natural physiological changes in thyroid function tests in pregnancy. I could give a whole talk, and apologies, that's too small for that to now project very well here, but I can give a whole talk about the factors that can produce funny thyroid function tests in patients taking thyroxine therapy. Can I just do a quick straw poll? Who has had coffee this morning? Wow, it's a lot less than in the UK. So clearly most of the people here are fine first thing in the morning. If you have a double espresso coffee with your thyroxine first thing in the morning, you will dramatically reduce the absorption of your thyroxine. Not many people realize that. Of course, there's a whole lot of medications that can do this as well. So it's really important that we think through, take a careful history of things that might be interfering before we start looking for other causes of unusual thyroid function tests. And then this at the bottom just shows the effect of heparin. What this is showing is a single blood sample taken from a patient who happened to have slightly higher levels of free fatty acids left on the side for varying durations of time. Remember, this is the same blood sample, aliquoted, and look how high the free thyroid hormone levels appear to go. Nothing else has happened in this sample. It was simply left sitting out of the freezer for different periods of time. And this is displacement. This is heparin displacing thyroid hormone. Now, this is very much an in vitro, in the test tube phenomena, because it doesn't produce thyrotoxicosis in the patient, because there is a re-equilibration. But in the test tube, there can be no re-equilibration. So it's important not to overlook that. So I have labored that, but this is where many of the cases that are referred to us are solved, by going back and looking at the story in a little bit more detail. And once you've done that, we can then come to the second stage, which is sorting out all the confusion that might have arisen in the laboratory. Now, laboratories have different approaches to this. There are laboratories that are, I've given you a result, that is the result, it is the correct result, go away. And there are laboratories that are very happy to talk to you about the fact that the result that you have may appear to be a good result from a laboratory quality control perspective, but is not the correct result in terms of the patient in front of you. Something has caused a perturbation of the assay. And I want to break these down into problems with the TSH assay and problems with the free thyroid hormone assays. And these are similar but different mechanisms. And to do that, I'm going to use an illustrative case of a patient who was referred through to our center. This is a gentleman who had standard primary hypothyroidism. He'd had this for many, many years, been stable on his thyroxine, once a year was having his thyroid function test checked. He had a little bit of past medical history from a vascular perspective and was on a combination of medicines, as you can see. By the time he came to our clinic, he was actually starting to show some features that suggested he had mild thyrotoxicosis. But originally, the blood tests that were done by his primary care physician showed TSH, which had previously been pretty normal, now raised with a free thyroid hormone level, a free T4 in this case, towards the upper end of the reference range. So the question is, what should you do at this point? Now, it's a little bit early in the morning, so I won't go around asking anybody in particular what they would do, but I can tell you what a lot of us would do in this situation, usually out of, I need some time to work out what's going on, which is we send another sample. And then we go, so now we actually have the same result, or in fact, perhaps it looks a little bit worse. Perhaps the TSH is a bit higher. So what are we going to do next? So in the spirit of what we were talking about, the crucial thing is to go back and re-examine the story and the history and check with the patient, and you will have some historical thyroid function tests. And you can see that actually dating back over several years, his thyroxine level had remained pretty consistent, initially a slight down titration from 150 micrograms to 125 micrograms a day. Everything looked pretty much okay. Probably can't see the laser pointer too well, but about a year before this first went wrong, perhaps the TSH was just showing a sign of going up. Not surprisingly, when the TSH rose, the free T4 levels were triggered, and as I say, they were towards the upper end. And in fact, what his primary care team had done was to watch the results and then say, no, this looks like we're really under-replacing now, so let's give a bit more thyroxine. And a bit more thyroxine was in the system, and at that point, nothing is getting better, and if anything, it looks like it's getting worse. And at this point, the patient came back to the primary care physician and said, no, I've known you for a long time, I really like you looking after me, but do you actually know what you're doing? Because actually now I'm sweaty at night, I've got a tachycardia, I think I've got over-replacement with my thyroxine. So actually, the blood test result here with the free T4 suggests the patient is correct, whereas the TSH suggests the patient and the doctor are at disagreement with each other. So remember, go back, what is the state of the patient? And the patient, by the time we saw them, was now genuinely thyrotoxic and was reporting thyrotoxic symptoms. So this means the conversation with the laboratory goes along the lines of, I have a patient who now appears to be thyrotoxic, but the TSH is telling me the patient is hypothyroid. So if we go back to our set of hexagons and we try to work out where we are, this patient started down here in the free T4, free T3, apparently normal with a raised TSH, and these are the conditions that are down here. Obviously, we're not really thinking about subclinical hypothyroidism. This gentleman's got overt hypothyroidism. We might start to think about whether there's something funny going on with compliance, because very strangely, patients will sometimes decide not to comply with medicines. And when they do that, they'll do very strange things, such as not take it, and then on the day they come to see you for their blood test, they'll swallow a lot of thyroxine at the same time. And in so doing, they will rapidly put their free thyroid hormone level up, and that will happen because you absorb the thyroxine quickly. That's the basis of a thyroxine absorption test, but the TSH won't fully suppress. So potentially, we have a whole group of conditions, and in the interest of time, I won't stay with why we exclude some of these quite quickly. But one possibility could be poor compliance. The second is there's now something wrong with the laboratory assay. By the time we saw the patient, he'd moved across to the other side. Remember, he's had his thyroxine titrated. He's now over here. And over here, again, in the interest of time, there are some common conditions that are crossing between these two sides. Laboratory assay interference, or again, possibly compliance. But why does compliance not feel right? Clearly, this man can get enough thyroxine in the system to become thyrotoxic. So the only way it could be a problem is if he's doing what I mentioned a moment ago, which is not dosing, and then taking a big dose before he has a blood test. So how do we resolve this? This was done very quickly. Health warning, this is not the way to sort out these funny thyroid function tests normally, or it comes with a warning because it doesn't always solve it. But in this case, it did it quickly. This is the same blood sample sent to 2 laboratories. So the patient was indeed correct. He's now thyrotoxic with raised T4 and a suppressed TSH. And this is whereas the original assay was showing the wrong results. And this is because there's a problem with the TSH assay. And you remember the TSH assay is a classical sandwich assay. The analyte, the TSH, is caught in the middle between 2 antibodies, capture and detection antibody, which has the tag attached to it. How do we get a false positive result? We get a false positive result if something else forms the bridge between the 2 antibodies. And all of us, or many of us in this room, will have antibodies circulating in the system, known as low-affinity heterophilic antibodies, which are capable of cross-linking the reagents in the assay kit. Sometimes you will actually have more specific high-affinity animal antigens. If you've had pets at home, or any other exposure to the animals in which the antibodies that are used in the laboratory kit have been raised, you may have antibodies to those, and that will also cause a similar result. So false positive TSH result. You can also get a false negative TSH result if the antibody which is interfering, shown down in the bottom here, somehow blocks the sandwich from being forming, either by binding to the capture antibody or the detection antibody. That now gives a false negative result for TSH, even though there is TSH in the patient's blood. I just want to mention this because this is actually quite an important condition. This is a different version where there is another type of antibody floating around the patient's blood, which has bound the TSH and is therefore reducing the clearance of the TSH from the circulation. So the TSH is not being removed, it's in circulation, but the epitopes that are required for the capture and detection antibodies to bind are still exposed. And so in the laboratory, the assay now measures the TSH that's there, free, floating around, and any of the TSH, which is complex to the 3rd immunoglobulin, which is circulating, providing a huge reservoir of apparent active TSH in the system, but it isn't active because the immunoglobulin bound to the TSH renders it biologically inactive. So confusingly, this is immunologically detectable, immunologically reactive TSH, biologically inactive TSH. And it turns out that this probably accounts for about 1–2% of all apparent subclinical hypothyroidism. So you can actually detect this, and this was a very nice series of studies which showed that somewhere between 1 and 2% of apparent subclinical hypothyroidism is not true. So in a patient who appears to have a TSH which is elevated in isolation with negative antibodies and no other features, it's definitely worth thinking about this, and most laboratories should screen for this. So the assay interference from a TSH assay could be heterophilic or anti-animal immunoglobulins, macro TSH. I haven't spoken about this today, but the presence of paraproteins can sometimes trigger abnormalities in the TSH assay, and when the paraproteinemia is dealt with, that goes away. And then down the bottom is almost the opposite of macro TSH. This is an unusual situation where a mutation in the TSH molecule, which leaves it biologically active, renders it immunologically unresponsive, as it were, because it takes away one of the epitopes that the laboratory assay is trying to find. So this is the opposite of macro TSH. The TSH is normal biologically, but you can't detect it. So the patient appears to have no TSH. So they appear to have a very strange pattern of results with normal T4, T3, and no TSH. And the question arises, are they taking something they shouldn't be taking? So how do we exclude TSH assay interference? We could compare between two laboratories, as I mentioned. We need to be careful about that. One of the easiest ways to do this is dilution, because these antibodies which commonly cause interference are fairly weak binding and can be very easily disturbed by simply taking the serum sample and diluting it 1 in 2, 1 in 4. So if you do a dilution in a patient who's got standard hypothyroidism, such as this patient, when you dilute 1 in 2, 1 in 4, 1 in 8, and you back multiply for the dilution factor, you get a very consistent result. The minute you have TSH assay interference, it falls apart, and the dilution is non-linear, and you can detect immediately. So this is one way of doing it. The gold standard is the gel filtration chromatography. This way you can detect the fact that the TSH is a much higher moiety in terms of molecular size because it has an immunoglobulin joined to it, compared to native TSH, which is that small peak from the control subject. Just another brief case just to show you the opposite where something goes wrong with the free T4 assay or free T3 assay. This is a patient who actually was felt to have possibly hypothyroid features, apart from the fact there was a history of palpitations. But whilst the TSH actually said yes, hypothyroid, the T4 said no, thyrotoxic. The laboratory needs to know you think this patient's hypothyroid. Repeat, and actually then subject to checking TPO, which supported the hypothyroidism and a negative TSH receptor antibody. What should we do next? What we did here was to send this same sample to all of these laboratories. And the great news is you can have whatever result you want. Because you can have a patient who's thyrotoxic if that's what you want, but if you send it to the next laboratories, the next two, the patient appears to have a raised TSH but normal T4, but over here the patient's hypothyroid. This is the same blood sample in 5 different laboratories. The one consistent finding is the patient has hypothyroidism by TSH. This is interference in the T4 assay. The T4 and the T3 assays are different. These entities are not big enough to bind to 2 antibodies. So this is a competition assay, old style. So we have immobilization complex with an antibody on a bead. We have a capture antibody. We have endogenous hormone, and then we have a fixed amount of a labeled T4 or T3, which is in a competition. And this is an equilibrium that establishes itself. And the more native T4 that is actually binding, the less of the analog and vice versa. So this is an inverse readout in an assay. So the higher the endogenous T4, the less fluorescence signal that you generate. How does this get interfered with? Well, if we happen to have something else in the blood, a third-party factor, if you like, that disrupts this equilibrium, such as a variant of binding proteins such as albumin or transthyretin, or anti-iodine thymidine antibodies, which can sequester the analog and the endogenous T4 away, that can perturb this. We can navigate this by keeping the different components of the assay apart from each other. So we allow the introduction of the endogenous hormone in the serum to interact with binding sites. We then add this crucial wash step, which removes any of the confounding factors, and then we bring the analog in when there is no third party to sequester that equilibrium. And therefore, the 2-step assay tends to work a little bit better. And when we do that in this patient, all those funny results are due to 1-step assays, and the 2-step assays give us the correct results. So the same result in a laboratory which is running the same type of assay could be the same wrong result twice. Just to bear in mind that variants of albumin, which are very common, so remember this is amazing, this is a genetic disorder that is associated with a laboratory assay artifact. This is a variant of albumin which has higher affinity for binding. So albumin has 4 binding sites for thyroid hormone. And in one of those binding sites, there are a series of arginines and tryptophan alongside the pocket, which actually then the thyroxine is competing to get into that pocket. And these side chains are providing a degree of obstruction to that thyroxine molecule going in. If you actually change that side chain and make that pocket more accommodating, you increase the binding capacity inside albumin. And in so doing, you provide a much bigger reservoir for absorbing thyroxine, either endogenous or indeed the competing analog. So just to say that depending on what type of assay you're using, you can get caught out in different ways, and you need to know this in order not to get confused. Very quickly, a word about biotin. Biotin used in pediatric practice, but also taken by lots of people. I won't ask for a straw poll of people here to tell me who takes biotin in the morning for their hair or fingernails, but biotin can interfere in assays which require the complex of a streptavidin-biotin complex to bind and immobilize the enzyme. So if you have free biotin floating around in the blood, which can get in the way of that complex between the two, it will then block the capture and antibody detection complex from being immobilized, and therefore they'll look like there's no TSH. In the free T4 assay, it does the opposite. Because there is no complex forming, it makes it look like there is no analog being bound, i.e. the endogenous hormone level is high, so you almost have the perfect disaster. You have low TSH with high T4. It looks like primary thyrotoxicosis. It's all laboratory assay artifact. Okay, just to finish, step 3, the specific considerations. I don't want to spend too long on this, but once you're down here, again, pattern recognition will get you a long way. So when you are faced with raised free T4, is it free T4 alone, free T3 and free T4, and what's happening to the ratio? And I just want to show you just quickly that, for example, when you're trying to distinguish a genetic disorder, resistance to thyroid hormone beta, from a TSH-OMA, you have to be meticulous. These are 2 patients who came to me in parallel. They have exactly the same pattern of results almost. Neither of them have got assay interference. One patient has a high prolactin and a pituitary mass. The other patient has a normal pituitary. Which patient has got the genetic disorder? You'd say it's got to be that patient over there. Which patient's got the TSH-OMA? It's probably this one over here. There's a mass in the cellar. The prolactin is raised. And guess what? It's the other way around. This patient over here has got genetic RTH and a prolactinoma. That patient over there has a histopathologically proven TSH-OMA. So assumptions can go wrong. And again, distinguishing between these is difficult. Thyroid hormone levels don't sort it out. TSH levels don't distinguish between TSH-OMA and RTH. Even SHBG levels don't, although sometimes the TRH response to TSH can do, because it's blunted in TSH-OMA and not in RTH. So response to somatostatin receptor analog can also predict which you're dealing with, because TSH-OMAs respond very, very nicely to somatostatin receptor ligand. And where is the lesion in that patient with the TSH-OMA? Well, the answer is it's actually just over here on the left-hand side. This is a PET scan using 11-carbamethionine before and after somatostatin ligand to suppress the TSH-OMA. And this is what's called a subtraction image, which is the difference between the 2 scans. So the displacement to the left and the difference of normality here is detected to show where that is. And therefore, we can combine lots of different tests, including genetics, measurements of thyroid hormone action, but these imaging strategies to distinguish between TSH-OMA and RTH-beta. And this was the last part of the algorithm where I would strongly encourage you to start thinking about consulting with somebody who has particular expertise in those areas. So what I hope I've done today is show you that actually a methodical approach, a stepwise approach, where you pause at every point, will help you to disentangle what is genuine hyperthyroxanemia, for example, and non-suppressed TSH, from some form of laboratory assay interference, or even something fundamental in the history or the medication list. Thank you very, very much for your attention, and I'm going to thank all of the people who work with me in Cambridge, and it's great to be back again. And if you want to read more about this, here are a group of publications which are relevant to the topic. Thank you for your attention again.
Thank you very much, Professor Gurnell, for the very informative lecture. I think that's quite useful for all of us in clinical practice. I think we have like about 2 minutes, just a quick question. I think this biotin is a common problem we encounter because a lot of the ladies who are referred with altered TFTs, with, as you said, sometimes with the perfect thyrotoxic picture, they are on biotin. So in that case, would you recommend like stopping it for a period and redoing the test? And how long should we wait usually?
Really important question. So in honesty, if you can discontinue biotin probably for 48 hours for most people, that's going to be long enough to be able to get the results. But generally, advising somebody to stop it for a week means you'll be definitely certain it's out of the system. Very occasionally, especially in pediatric practice, if very high doses are being used, you need a little bit longer. But normally for most people, taking a supplement, literally a day or 2 would be more than enough usually.
Thank you very much. Thank you.